Yeah, you can begin, Meenakshi.
Yeah. Thanks, Dr. Sinha sir, for the wonderful opportunity given to me. This is really a Herculean task that a single individual is conducting a CME program. That too, extracurricular subjects like insurance, finance management. Now it is a legal management. And I am very happy to see Dr. Shivakumar Kumbar, Dr. Madhusudan Upadhyaya, Dr. Nagnath Mastud, and many people are there. And I am really fortunate to share my views on laws related to anesthesiologists. Okay, now what I am going to tell now, or what Dr. Maheshsinha wanted me to tell, first is how to practice legally. See, I am not going to give any lecture on this legal format, which would be boring. What I am going to do, I will give only the judgments so that you can deduce the information how to practice. And again, what are all the medical legal subjects that governs anesthesia practice? So again, that also only by way of judgments. And at last, if you receive a legal notice, how to manage that? That's what I'm going to tell now. So, as a legal person, I want to say this is a warning. Uh, the cinema in movies, it will be said all are imaginary characters and nothing resembling, if something resembles to a reality, it is only coincidental. Same way, I have used these judgments for some illustrative purposes, and you should not keep it as a substitute instead of seeking a competent legal advice, because we know as a doctors self medication is always dangerous, but a little bit of legality we have to know, because we have to feed the lawyer, so we have to read the legal materials also. Now I want to tell all of you, some people are having that inferiority complex, how we can read law. When we are in the court, we are tensed up. Many people have asked me, but I used to tell only one thing. See, if you see a patient like this, you are not worried. Then why you are worried in the court? That means you are not used to it. So even if a patient is like this, you will be seeing a pupillary reflux. So what I want to convey, the doctor is active in others' crisis, but when it comes to them by legal notice, they want to run away from the scene. They are worried, they are upset. That has to change. So, but what happens today? The legal notice against the doctors are steadily increasing day by day because of the awareness among the consumers, that is our patients. So we have to know the legal issues, because as I said already, we are going to feed the lawyer. See, whether the lawyer wins the case or loses the case, he is getting his fees. All legal fees are prepaid only, straight from the magistrate court to the Supreme Court. All fees are prepaid. So their money already they have received. So they need not bother about the outcome. But if we lose the case, our reputation is at stake. So we have to know the legalities, but the best policy is to adapt in medical legal issues is prevention is better than cure. So what I want to say, people are worried about legal problems because doctors, like any other person, they have a social stigma of meeting police and lawyers. But it is a must. Many of my friends are police and lawyers because they can only spoon feed us. We cannot read everything. So it is better to listen than to read. So you have to avoid the social stigma of meeting the police and lawyers, and doctor should not be ignorant of negligence. And the worst problem is the legal people don't understand the intricacies of medicine. That is the reason why we are getting caught unnecessarily in medical legal tangle, because the lawyers they read textbook like this so much. And I want to say again, please, doctors, I request all the doctors not to argue. that we don't have time to write, how we can write while we are concentrating on the case, how we can write the notes when we are anesthetizing a case. Please, no arguments. As a legal person, I will not answer those questions. And what I want to convey, there is no definite law as far as medical negligence is concerned. So every case, it is the interpretation of the judge. That is the reason why I want to give information based on judgments. And judgment varies from judge to judge. That is the reason why the lower court acquits a person, the higher court says he is guilty, and the reverse also happens. So, and most of the time, 100%, the judge is a non-medical man. So, what we have to know, the court, the Supreme Court held that who are all negligent. Doctors are professionals like lawyers. So, a professional can assure that he is possesses of the requisite skill in the branch of profession. So if I say anesthesiologist, I need not be extraordinarily smart like Dr. MaheshSinha. If I am an average anesthesiologist, it is enough. So the law demands I have to have the qualification. So if I say that I am a qualified anesthesiologist, I have to substantiate what qualifications I have. And if I have the average skill, that is enough for the court. So if a doctor is held negligent, there are three components: duty, breach, and resultant damage. They should be used by the advocates who are suing us. And when we are defending our case, we have to be very clear whether these three parts are fulfilling the criteria. That is, we have to accept a patient. So there should be a duty. And we have not supposed to do the duty properly, or by negligence, if the duty is not done properly, it is called a breach. Even if you have omitted to do your duty, you will not be negligent. That omission of duty should have produced a damage. So whenever a person issues a legal notice against you, you please check whether you have a duty bound to that particular patient, and whether you have breached that duty, and if that breaching of duty has resulted in damage. Only if three are fulfilled, you are negligent. So this is a standard case, the Jacob Matthew versus State of Punjab, 2005. I request all the doctors to go through that. See, the lengthy lines denote only this: negligence is a breach of duty. But why we have written so many lines? The judgment is quoted as per the judgment. So most of the time, the judge is a non-medical man, as I said. So they elaborate. There may be grammatical errors. There may be spelling mistake. But I want to say, as the level of the court increases, like in the Supreme Court, all judgments will be very fine. So they also go through reasonably the textbooks as well as the case sheet. So this is said in the judgment. It is duty, breach, resultant damage. So a simple lack of care or error of judgment is not a proof of negligence. This is what Supreme Court has said. So if there is some oversight which has produced only a minor injury, that is not a negligence. So when you are defending your case, even though your negligence is gross, you have to argue, because there is no other way. You have to defend yourself, so that you can call it as an error of judgment. So that is not a negligence. So the Supreme Court has held, so long as a doctor follows a practice acceptable to the medical profession of that day. I want to say of that day, because 20 years earlier, I would have practiced a technique, and now the technique would have changed, but I should not be called I am negligent because I have done it 20 years ago. So the court has made it very clear, we have to follow a practice acceptable to the standard. I will give some judgments where the anesthetist has not practiced according to the standard. And as I said, if Dr. MaheshSinha is professionally superior to me, I cannot be equated with him. If I should practice in an average way, I need not match the standard of an extraordinary person in the anesthesia society. So this is another case, Dr. Harish Kumar Kurana versus Joginder Singh. It is 2021 Supreme Court case. It has made it clear that every case the doctor will not be successful like a lawyer. So if there is a failure, it is not automatically, it is not becoming negligent. So if a person wants to sue you against negligence, he has to prove it and he has to produce the evidence. Except in a res ipsa loquitur, you have to be very careful. The person who is filing a case against you, they should prove that you are negligent. And incidentally, I want to inform the audience, I am writing a legal series in the SBV journal, which is coming from Pondicherry. Dr. Parth Sarathi is a chief editor for that. So 2 articles have come in that. I am writing a series. So once in 3 months, the journal will come and I will circulate the soft copy also. Now we will come by judgment so that you automatically derive conclusions. What I want to say, instead of saying the informed consent should have all the qualities, I am saying the judgment. So this is a Kolkata case. See, yeah, anesthetist has got a consent in a blank form, and the court said there is no signature of the doctor. So now I want to inform all of you, because no, I think only 5% will be practicing like that. So a consent form should be signed by both the parties. That is the first point I want to tell today. The consent form, because every time we are getting a consent from the patient, but we have to inform our name and introduce ourselves, and it has to be signed by both the parties. Then only it is a valid consent. So even if you practice in a genuine way, if there is a clerical error, it will be held negligence. So the court said, just because the doctor has not signed, he cannot escape his liability because there is no proper consent. So another consent case. This is a UK case. A diclofenac suppository was inserted in a female for pain relief, but because the suppository melted, the patient sued the doctor that there was a sexual assault because of that. So without a consent, introducing a suppository is also a negligence. And another problem is the patient wanted to have GA, but the anesthetist is given spinal. So the patient developed paraplegia also. So even though spinal anesthesia is a backstabbing, you are not supposed to backstab the patients in a illegal way. That is, I want to inform there should be a separate consent for anesthesia. And if there are any major procedures which are invasive, then that requires a separate consent. So be careful. And this is an interesting case in Tamil Nadu. Even though it has occurred in 1992, I wanted to quote this judgment because some judges interpreting this way. See, the doctor has not taken a written consent for a thyroidectomy. For the patient died actually, but there was no consent, and the surgeon argued that I have asked my staff nurse to take the consent, but she has failed to do so. The judge opined, see, even though a written consent was not there, when the patient was wheeled inside the theater, till anesthesia is induced, she is conscious. That means she knows that she is going to undergo surgery because premedication is given. Relatives are also aware because they are accompanying the patient up to the theater. So it means the judge concluded there is a oral consent. So he has dismissed the complaint. He held that the doctor is not negligent. Now I want to tell you, even if it is a consent, there is a oral consent, another one is a written consent. So if a judge is good, he can say oral consent is enough. But to be on the safer side, we have to have a written consent, because written consent, the patient cannot say that I have not given the consent. So that is the basic difference, oral and written consent. So this is the one, but don't think that all the judges will be like this. Sometimes immediately the judge will be offended that you have not taken a consent. So this judge is a good judge. So the judge is like this lady, but most of the times the judges will be like this. So to be on the safer side, we have to have always a written consent. Another consent specific. Consent must be procedure specific. See, the Samira Kohli Prabha Manchada case, here I have written it. The first article in my legal series is only the Samira Kohli and Prabha Manchada. It is a lengthy judgment, but I request all of you, please take that. That is Consumer Protection Judgment, 56 Supreme Court. Please read Samira Kohli and Prabha Manchanda, because elaborately the judge deals with the consent, the pros and cons, and definitely the judgment would be acceptable to all. So it should be procedure specific. Just because you got consent for one procedure, it doesn't mean automatically that you can go for another procedure. There should not be a blanket consent that I am ready to undergo anesthesia. It should not be like that. I am ready to undergo spinal anesthesia by Dr. Meenakshi Sundaram. That should be a consent which should be signed by both the parties. And another thing, if you are under transfusing blood, definitely a separate consent is to be there. See, in the Kerala High Court ruled, the name of the anesthesiologist needs to be mentioned on the consent. So it is a rule. It is a rule, but every time the court says that it is omitted, omitted, omitted. So we have to be very careful. So this Mekula is a good judge, UK. Same way, our Dr. Lahoti, who was the Supreme Court Chief Justice, he has delivered very good judgments. So I request the people to browse Justice Lahoti, Lahoti. He has given wonderful judgments regarding this Consumer Council. So you go through that. And even the UK judgments we are practicing. So in the law registry, the Mekula has given a good judgment. And that we should know as an anesthesiologist. See, the patient has given consent for general anesthesia, but for post-operative pain relief, caudal anesthesia was given. So there was a persisting numbness in the left leg. So the patient sued the anesthesiologist that I have not given consent for caudal. But Judge Lord Mekula, they used to call him as Lord Mekula, he has held it need not be, because that caudal anesthesia is for a part of pain relief. It is part of anesthesia. So you need not take sectionalized consent for everything, for every procedure. But it is always safe, as I said. Caudal anesthesia is an invasive procedure. But Lord Mekula held, why should a separate consent also for morphine injection? If you are giving a shot of morphine for postoperative pain relief or cletidine, then the patient cannot argue that you have to have a separate consent for cletidine injection also. So he has held it in a very good way, as he is a good judge. See, he has quoted another thing in the judgment. See, then how long will it be before the court is invited to say that separate consent should be sought for separate steps in surgery? Like, if it is a inguinal herniorrhaphy, then the surgeon can take a consent only for inguinal herniorrhaphy. He cannot get a consent for incision of the skin, incision of the subcutaneous tissue, then for hernia repair, then for placing the mesh. So it is a sectionalized consent. But as I said, the judgment varies from judge to judge. But why I am quoting this judgment? If suppose you have failed to take a consent for a particular portion, then as a defense you can quote, See, already there is a judgment that a sectionalized consent is not needed. That is the reason why I said we have to be very careful in reading judgments, because if the lawyer is not aware of this judgment, then he cannot argue the case in the court. So it is always better you have to know some legal problems. But as I said, the judgment differs. See, it automatically, if you look at this, both the sides are same. But if you look in a concentration, both the sides differ same way. The judgment differs. If you say this is good, then there may be some judgment saying that it is bad. So we have to know both, because we may not be knowing which side we have to cut. Consent case, this is also Texas case, but we all should know, because this is the funniest judgment. See, consent was obtained from the husband for appendectomy for his wife, but wife said my consent was not taken for appendectomy, and she had persistent numbness on the right side of the leg because of the spinal anesthesia. So the wife said my consent has not been taken by the doctor, but the local court ruled the husband has given the judgment. So she has lost the case in the lower court. But I don't know what is the problem between the wife and the husband. She appealed in the higher court. The higher court ruled, yes, wife is right. Just like all husbands, court also said, wife is always right, because there was no consent that the patient's spouse was authorized to consent on her behalf. I request all of you to read the judgments, because sometimes the words play is very good in judgments. See, what a judgment. There was no consent that the patient's spouse was authorized to consent on her behalf. So what I want to convey, the husband can give consent, proxy consent for his wife, but before that, the wife should have given consent that husband can give consent on behalf of her. It may be confusing, but that is the word. The court held the husband and wife relationship does not in itself make one spouse the agent of the other. So be careful. If anybody is aged more than 18, it should be from the patient only. And when the reproductive organs are removed, there are varying judgments, but it is always better both the parties, that is wife and husband, should sign if there is any problem with this pregnancy or removal of the reproductive parts. So the lessons to be learned: informed consent always take, and the unconscious patient, you can operate upon unconscious patient, but once the emergency period is over, then you have to wait and take the consent from the patient. That is the case of Samira Kohli Prabha Manchanda, which I mentioned already. So informed consent is compulsory. Implied consent is only in emergency. So the Samira Kohli case, the patient was given a consent to undergo laparoscopy. But on laparoscopy, it was found that the patient had endometriosis. So they have done abdominal hysterectomy with bilateral salpingo-oophorectomy. The patient's age is some 47. But the patient sued the doctor that she was yet to get married, and because of the removal of uterus, she cannot get married, and because of the removal of ovaries, she has to undergo hormone replacement therapy. So the doctor is liable, but the court has dealt with very extensively, and the court held, even though the doctor is not negligent, she has not taken the proper consent, because she has taken consent only for laparoscopy. So you have to match it with anesthesia. So the Supreme Court has ruled what are all the points in consent. So the adequate information to be furnished. That is, doctor should disclose only the reasonable complications. See, this judgment you have to read, because sometimes we will say the risk may be the patient may die on the table itself, death on table consent. But that is not accepted because the court in this Manchanda case, Supreme Court has clearly dealt with the consent, and it says if the doctor is coming out with all the remote possibilities like death on table, then the patient may refuse treatment and they may seek alternate modes of treatment. That should not be done. So the court wants to be very careful. Even you can argue, if you read this case, informed consent is not at all needed as per the court, because the court says here in this case there should be a valid consent or real consent. The difference between informed consent and the real consent is real consent, if the reasonable complications are explained, it is enough. But in informed consent, even if it is 0.000001%, it should be explained to the patient. So the real consent is practiced in United Kingdom and informed consent is practiced in United States. We are following only United Kingdom. So our Supreme Court in this judgment has held very clearly the primary health centers, the village areas, the level of education to the public is very low. So the public should not be threatened by the complications with the treatment. So remote possibilities we need not explain. So consent given only for a diagnostic procedure cannot be considered as a consent for therapeutic treatment. So if you are getting a consent, it is valid only for that procedure. Then please don't argue that this is a problem, that is a problem. That is the reason the court has clearly said these are all not grounds of defense, because we will say I cannot anesthetize twice. If suppose you are getting a consent for left herniorrhaphy, if you are given spinal and even if the time is more, patient is having a right side hernia also, they cannot do that. Both are liable, anesthetist and surgeon. So if the patient has given a consent only for a particular procedure, it should be only for that, no additional procedures. Because as an anesthesiologist, I have seen the surgeons while doing hysterectomy, they will remove appendix also, even if it is normal, because they say they are avoiding the second surgery. It and all not relevant, so we have to be very careful on consent. No consent required when you need not take a consent in medical emergencies. Here, the court says in a medical emergency, the medical considerations takes over legal considerations. That is a word play. Same way, notifiable diseases like COVID, cholera, tuberculosis, because by statute, by a law, they are made as notifiable diseases. So in medical emergencies, medical considerations takes over legal considerations. In notifiable diseases, legal considerations takes over medical considerations. And again, the immigrants, members of armed forces, food handlers, prisoners, these at the request of police, the consent is not required. So the implied, what is the implied consent? So if a person is coming like this, how we can give a consent? So you can operate. That means the patient has automatically consented because the patient is seriously injured. But once the emergency treatment is over, then the implied consent does not govern. So you have to get a informed consent in a written format. Then comes expert witness. Even I have written an article about expert witness is not needed in all the cases. As far as the expert witness is concerned, if you are sued by a patient, you can arrange another anesthesiologist as an expert, but that expert witness can be cross-examined by the patient's advocate. So you have to be very careful. In expert witness itself, the Supreme Court, this Kishan Rao and Nikhil super speciality, that is a case I elaborately dealt in that article. In this case, the court has made it very clear. Expert witness can be decided only by the court, not by the patient himself. Because even if injury is very obvious, we need not get an expert opinion, because in this case, the malaria patient was treated as typhoid. So the lower court, the district forum, held the doctors are negligent, but the doctors appealed in the state forum. The state forum opined there was no expert witness to substantiate this. But the National Commission on appeal by the patient, it has held very clearly. See, patient is suffering from malaria but treated for typhoid. Why a expert witness is needed for this? Like, if suppose to amputate a left-sided upper limb, if a right-sided upper limb is amputated, then why to get an expert opinion for this? Because this opinion is decided by the court. There cannot be a mechanical or straitjacket approach that each and every case must be referred to experts for evidence. Because the Supreme Court, the CJ, Justice Lahoti has pointed out, if suppose a doctor is sued by the patient, then there should be some prima facie, some evidence. So because at the end, if the doctor is killed, not negligent, then his reputation at stake, he has to travel to the court, everything is there. So before issuing summons to the doctor, you have to get a medical board opinion that there is prima facie evidence or some problem has occurred. Then only the summon is to be issued. That was reversed by Justice Ganguly, who was elevated to the Supreme Court from Chennai High Court. He only reversed and he has delivered this judgment. It need not be a straight jacket approach. So we have to know when to use that judgment and when to use this judgment. But as far as that expert witness is concerned, the court is not bound in every case to accept the opinion of the expert witness. So don't think that as an expert witness, if you go, that is the rule. No, it is not like that. So the National Consumer Disputes Redressal Forum in Uma Devi and Yashoda Hospital case, a 42-year-old patient for ERCP and sedation, propofol was used, cardiac arrest, revived, became brain dead. The expert committee constituted by Osmania General Hospital on the instructions of police authorities held there is no negligence. But Andhra Pradesh State Consumer Forum held hospital and doctors negligent and awarded 10 lakhs as compensation. So the expert opinion, the court need not go by expert opinion because the Andhra Pradesh State Consumer Forum has held the anesthesiologist must carefully watch for changes in blood pressure, oxygenation, and patient reaction. This is what the court has said. And required to carefully document the process, which you minute to minute. See, the court says minute to minute. Don't argue with me how you can record it from minute to minute. It is the Andhra Pradesh State Consumer Forum. And that Andhra Pradesh State Consumer Forum mentioned in that judgment, in some hospital, the anesthesiologists are allowed to read books during the surgery. Or if not allowed, in fact, it will be seen doing that. The youngsters are playing with the Facebook and WhatsApp in the theater. So now we have to warn them. The court has mentioned like this. And another thing, the court has mentioned some people have license to wear their headphones and listen to music. That means, see, the anesthesiologists are not respected by the court at that particular point of time. And the court, the Andhra Pradesh Forum has held, the unconscious patient is unable to appreciate whether the attention has been given or not. And they have analyzed the case sheet and mentioned that the case sheet shows young healthy patient sustained cardiorespiratory arrest and brain damage. So even though the expert opinion said there is no negligence, the court is not ready to accept it because they are analyzing the case sheet. So indirectly, anesthetist should know the case sheet is to be maintained properly. So the court has held that indicates anesthesia was excessive and a timely intubation was not done for the patient. These are all the court findings. And unfortunately, the court clearly mentioned there are no reading between 3:30 p.m. to 3:50 p.m. That is 20 minutes. See, 20 minutes, some people will say, and doctors, what the big problem in 20 minutes? But this court has held minute to minute basis, it should be recorded. So the 20 minutes there was no notes. So the court held that doctor is negligent. So indirectly, what I want to say, anesthesiologist can have monitoring benefit. They have to monitor the patient, but not monetary benefit. That is the rule of the day. Whether we get the monetary benefit or not, we should give the monitoring benefit. What is important to escape from the negligence? There should be a proper communication, and you have to document the communication and communication of the documentation. We have to say that we have documented this. And again, documentation of the communication and preservation of the documentation. So these five, please remember: communication, documentation, communication of documentation, documentation of communication, and preservation of documentation. Then the anesthesiologist will say, if I am going to that hospital, that pulse oximeter is not there, but if I refuse the case, some other anesthetist will take over. So what should I do? This is a routine question the anesthesiologist used to ask me. Then I will give that preoperative infrastructural assessment, again judgment only. It is not my lecture. I will give the judgment. You decide how the court views it. The court says it could not be said that anesthesiologists could not be criticized for the unavailability of equipments which are unreasonable in rural setup. Because the court says human life is a human life, whether it is a primary health center or a corporate hospital. So must take all reasonable investigations. Then the court also gives the clue. If suppose something is not there, if you are operating, because what I feel, most of the nursing homes, that is small nursing homes, they may not have a ETCO2, they may not have a defibrillator. Defibrillator, most of the nursing homes may not have. But the court gives the clue how to do that for the anesthesiologist. This is a typical case. This is Gujarat, Aruna Bendi Kotari versus Navdeep Clinic. See, a young man were posted for plate and deformity correction. Cardiologist has given fitness. That is a routine. These people, for that is a BP of 150, 100. The cardiologist have given fitness. Actually, anesthesiologist should give the fitness. But halfway through surgery, the patient developed cardiac arrest and died. So the court said the complication has occurred within four walls of the operation theater where the patient's relative had no access. That is a problem. So the doctors has to explain what had happened. So neither the anesthetist, nor the surgeon, nor the cardiologist was able to explain how the death of the patient happened. This is how the court views. See, the anesthesiologist, who is a lady, she argued the defibrillator was not available. This is how we are getting caught. See, the court wanted to know how the death has occurred because it has happened within the four walls. Then the anesthetist said it is due to ventricular fibrillation, but the cardiologist has given fitness, ventricular fibrillation, defibrillator not available. If it is available, I would have given a defibrillation. This is the argument. The same way, corollary, another case in Tamil Nadu. See, a patient thyroidectomy was dead on table, but the anesthetist is given in the counter affidavit that the patient was obese. She wanted to give intracardiac adrenaline, intracardiac, but the needle tip has not reached the ventricle because of the obesity. See, now we are always against intracardiac adrenaline. Without knowing, just like a child, they are giving a counter affidavit. I am not having a lengthy needle. If there is a lengthy needle, I would have saved the patient. But the court has very clearly held, because the court is not aware, intracardiac should not be given. It should be given only intravenous followed by a driver dose of normal saline. The court is not aware of all these things. See, it is pricking our eyes with our own fingers. The court said, right, we accept. If there is a lengthy needle, you could have revived the patient. But seeing the patient as obese, you would have already arranged a lengthier needle. That is the court. Same way, defibrillator not available, So the State Forum Gujarat said, this is the lesson for all anesthesiologists who say that we are not having adequate infrastructure. See, the court said she should have procured the same as a precaution before starting anesthesia. Okay, court says, okay, not possible. I cannot procure the machine. Then what should I do? Should have brought these facts to the notice of the patients and relative. You have to inform the defibrillator is needed, is not available. Now you are not supposed to say, if I say so, the hospital will arrange another anesthetist. Let them arrange. You are morally bound to help the patient. So you should have brought these facts to the notice of the patients, or could have refused anesthesia without the said machine. This is what I say. Even the court has mentioned. If suppose something is not available, please try to procure that. If it is not possible, explain it to the patient and the relatives, or refuse the case. This is my opinion also. So in that particular case, the court has awarded 4,15,000 rupees. Why I am saying that, there is a point. Out of this 4,15,000, the court held 60% should be paid by the anesthesiologist, 30% by the orthosurgeon, and 10% by the cardiologist, because the anesthesiologist is responsible for this. Now, my point is, if the case is successful, what will be the share? Anesthetist will get only 5%. If so, that is the plight of anesthesiologist. We have to be very careful. So, blood, separate consent is needed. It should be made available in adequate amount. If there is a rare blood group, please arrange blood and then proceed with surgery, because the National Commission has held the doctors have not arranged adequate blood. So that is also a case. Paralysis of lower limb after spinal anesthesia. See, this is a very pathetic case. It is occurred only 7 years earlier. It is by National Commission. Elective LSCS was done under spinal anesthesia. Paraplegia occurred. District and State Forum held anesthesiologist negligent, and the anesthetist appealed in the National Forum. See, the anesthetist argued the case as the spinal anesthesia, there is an inherent problem of epidural hematoma, so it has occurred. But the National Commission has very clearly mentioned, see, the MRI spine has showed hemorrhagic collection and edema anterior to spinal cord from the level of T12 to L4, compressing the spinal cord. But the patient was referred to the neurosurgeon and evacuation of the clot was done on the 4th day after this epidural collection. So even as doctors, we know there is a problem. Why they have delayed for 4 days? So the anesthesiologist was held negligence and 12 lakhs was awarded as compensation, but they have divided it equally. For hospital 4 lakhs, anesthetist 4 lakhs, surgeon 4 lakhs. Again, people will ask whether the copy of the case sheet is to be given to the patient or not. There are conflicting judgment. So one says no, Maharashtra Medical Council says yes, but that no is a higher court. But if a copy of the case sheet is asked by the police or the court, you have to give for a patient, a full-fledged discharge summary is enough. So we need not give a copy of the case sheet to the attenders on demand. Again, hypoxia and brain damage, because most of the time the neurophysicians, all neurophysicians, if anesthesia has been administered, mainly the GA, they will say hypoxia, brain damage. Spinal cardiac arrest, they will say hypoxia and brain damage. So in the Aruna Kothari case, as we mentioned, that defibrillator case, compensation award, because the cardiologist has given fitness, then how can a cardiac arrest occurs? This is a court. Court is not aware that our anesthesia depresses the heart. But the court said, the cardiologist has opined it is a fit heart, so cardiac arrest cannot occur. And the specialist opinion, neurophysician said, oxygenation was improper during cardiac anesthesia. So, for that brain damage case, I am quoting this case, already I have mentioned. See, this is not practiced nowadays. But what happened? This case occurred in 1969 when I have joined first year, not MBBS, first standard. So at that, why I am mentioning this judgment now is, this judgment was delivered in only 1990. So 21 years after the incident, the judgment was delivered. Oh, the fun is, the tonsillectomy was done without an endotracheal tube. Can you imagine? Tonsillectomy was done in a case without an endotracheal tube, because then only I realized, this is when I was studying first standard. At that time, what they have done, I have read the judgment. See, first they will intubate. It is just like an open ether. First they will intubate, then they will give ether after that spontaneous anesthesia. And once the patient is under, if you put a Boyle Davis mouth gag, we will check whether the endotracheal tube is compressed or not routinely. Sometimes a Boyle Davis gags will have a groove also to accommodate the endotracheal tube. But in those days they have done, they will give ether to endotracheal tube. Once the patient is under, they will remove the endotracheal tube. They will put a Boyle Davis gag and they will operate. It was like that. This case is like that. The court has mentioned the anesthetist removed the endotracheal tube immediately, and he was not inserted when the patient suffered a respiratory arrest. So the patient suffered a respiratory arrest and a cardiac arrest, but that amount of compensation awarded was only 50,000 rupees, because at that time, 1969, the father, he is an engineering graduate, best outgoing student in school, but it was awarded only 50,000 rupees at that particular point of time. But these are all the things, is gross negligence. So it is not acceptable today. It is not acceptable practice. Just for fun, I have added that. So when you are transferring the patient, that is also anesthetist responsibility. So when you are transferring the patient, the Supreme Court has held, it is the duty of the doctor to render all possible help to the patient until he reaches the spot. The anesthetist, that is the concerned doctor, should extend all possible help. See, in a case of Maharashtra, the patient was transported in an ambulance. Pakka ambulance, he was transported, but on the way, oxygen cylinder got emptied. So the patient died because of the hypoxic arrest. So 4,10,000 was awarded as compensation. Pakka ambulance, but oxygen failure. But in Kerala, a doctor has transferred the patient in a car. And the doctor said, I have opened the rear door. From that, the oxygen cylinder was kept. And I had a foot suction. So when I was driving the car, my helper, he was applying a foot suction. So suction was administered and oxygen was given, but the patient was transported in a car. That patient also died. But the Kerala State Consumer Forum said that is allowed. The doctor is not negligent because he has applied suction and he has administered oxygen. Whereas in Maharashtra case, oxygen was not there. So what I want to convey, even if you transport a patient at the sky level, just like a flying, you have to mention that you have applied suction and you have administered oxygen. That is quote. So the lessons learned, treat the patient. If not possible, manage the relatives, because they are the living people who are going to sue you. If not possible, treat and manage the case sheet properly. So if it is also not possible, then lose all your hard-earned money, what you have earned in the previous years. If a patient refuses, informed consent may be in an oral form or in a written form, but informed refusal, compulsorily it should be in a written format, because the burden of proof solely lies on the shoulders of the doctor. So if a patient refuses something, you please record it, or else it is called a battery, because Jehovah's Witness, they refuse blood transfusion. So never venture with the blood transfusion in Jehovah's Witness. And see, I will give some cases where anesthesiologist held negligent. A patient requests the anesthesiologist not to use the left arm for injection, but the doctor used the left arm only. Actually, the thiopentone extravasated and the patient developed pain. Then the patient sued. So in the Ontario High Court, it was held the patient not wanted the left hand injection, which was done. So anesthetist is negligent. Then regarding in a teaching institute, people may ask, what about the PGs doing the cases? Even today morning, one HOD asked me, what about the postgraduates managing anesthesia? See, there is minor surgery, but not minor anesthesia. So you have to delegate the cases only to competent persons. You can delegate to the qualified assistant, but PG is a student. He has come here to learn. So if a PG manages a case, automatically the supervisor, the assistant is held responsible, whatever happens to the patient. Then the postmortem also, one chief frantically asked me, a patient, a elderly patient, 69-year-old lady with all complications died perhaps, but to be on the safer side, they wanted to do postmortem. So he called me and asked what to do. And they want to be on the safer side. Patients are not willing. See, here I want to say the State Consumer Forum Gujarat, it said you have to prove what is the cause of death. The doctor has to prove the cause of death. So you have to do postmortem. But the National Commission said when the cause of death is not in doubt, if you are ready to certify, if you are ready to certify the death is due to cardiorespiratory arrest or whatever diagnosis you offer, you need not do postmortem. If the death is in doubt, you have to do postmortem. So, in the theater, perioperative death, it is occurring in the four walls. To be on the safer side, the doctor may like to subject the body to postmortem. But I want to make it very clear, the postmortem cannot be decided by doctors or the patients. See, you have to file a case in before the police. So only the police decides and they seize the body and subject it to the postmortem. So the legal postmortem is decided by the police. If the clinical postmortem is not practiced in India, so we cannot do it on our own to find out the cause of death. So if the cause of death is in doubt, you have to file a complaint to the police that the cause of death is in doubt. But as a doctor, we are not having a doubt as far as the cause of death. So usually the patients prefer a complaint before the police. And if the patient's attenders are not willing for postmortem or a police complaint, it can be given, taken in a written format and we can dispose the body. Then I want to give a clue to avoid litigation. To avoid litigation, never be angry with the patient and don't charge too much like a bank robbery. Mainly, if you expect a problem, don't insist on fees if you expect a problem. See, I'm very careful as a legal person. I want to use the word don't insist on fees. I'm not saying that you leave them free because if you're not charging them, that means they will have a doubt. Doctor has done some mistake, so he is not charging us. So don't insist on fees if you're expecting a problem and explain everything without any bias. So if you receive a legal notice, never go for out of court settlement. This is my personal opinion. Fearing reputation because it will recur. If you go once for out of court settlement, every time it follows, the patient's attender will inform 10 people, all the people will come for that. And if a doctor has not received any legal notice, if a doctor says, mainly anesthetist, I have not received any legal notice, it means he may not be a practicing doctor or he may be a PhD doctor. And if you receive a legal notice in the court, never irritate the judge because he is your examiner. This is just like a postgraduate passing the examination. He should not irritate the examiner. So how to choose a lawyer in case if you get a legal notice? It is always good to have a lawyer who knows law. And it is better to have a lawyer who knows medicine also. But it is always the best to select a lawyer who knows the judge mentality. That is the practical management. Mental makeup of the judge should be known to the lawyer. So that lawyer is the best lawyer. So the carry home message, lawyers and public are dancing on the shoulders of doctors because the doctors are soft targets. So they may harass doctors even for flimsy reasons. So to avoid litigation, be friendly with them. Avoid litigation. Even these orangutans are loving a human being. So you be friendly with them, avoid litigation, and enjoy life. Thanks. Thank you, sir.
Thank you very much, Meenakshi. As usual, as witty and with your case laws elaborated quite widely, although it is a very vast subject, as you said in the opening remark. But I think all those who attended must have got a good glimpse of what they should do and what they should not do. There are few things in the chat box. I'll just check. Uh,
Dr. Sinha, sir, I'm happy 81 people have attended.
yeah.
That's a good thing.
In emergency, should we take relatives' consent of patient? Cannot patient give consent? By this, we can have inform about the risk.
Sir, I was very clear in that. See, in emergency, even if the no consent you can operate because that is an implied consent in emergency. But once that emergency part is over, even it may be a 45 minutes part, then if the second surgery is needed, separate consent is needed. So emergency is a ground, it is a shield. You can proceed with the relatives' consent. But once the emergency part is over, complete consent from the patient is mandatory. That is the Prabha Manchanda case.
This question about professional indemnity, actually, this has been covered lucidly in one of the previous our webinar. So we can go through that.
Sir, I think
Dr. Kumbar is liked you. It was very nice presentation. Thank you, sir.
is there
If
any
anyone,
legal way, sir? One question is there any legal way in institutional practice when postgraduates are doing intubation and breaking tooth, will the concerned senior be held responsible? Yes, definitely responsible. Definitely responsible. Then, in case of handing over of long cases to our colleagues, how should we document it? Right. So this is a correct point. See, the court allows handing over the case to the equally competent doctor. So we can hand over to a qualified anesthesiologist. At the time of handing over, it should be recorded in the case sheet and you have to write the findings and it has to be handed over. Once the anesthetist accepts, if anything goes wrong after that, it is only the second anesthetist held responsible for that because he has accepted to take it over from the first party. So that is the question he has asked.
another one is if there is a change in plan of surgery during surgery, what is to be done? I think you have already said about in the Pratibha Manchanda case, what is to
Yes,
be
I have
done.
said everything. Sir, I expected the questions, sir. That is the reason why I have inserted the slides. So I have taken the full 1 hour because I wanted to inform. Because I thought what are all the possibilities the people will ask. So I think even I am happy that mostly it is covered. Dr. Kumbar sir is raising his hands. He is our legal person, but
Yeah,
usually
just a moment. Please unmute, sir, yourself.
Yeah. Thank you, Dr. MaheshSinha's. It was very nice presentation. You have covered from pre-operative room to the court hall. Okay. And even beyond that also include the transportation. And my special compliments to you.
thank you,
And
sir.
the my eye opener Samara Koile versus Manoj Chand case. And as you rightly said, now it is called as informed, real, valid consent. Okay. Yeah. And risks, remote risk of the harm, 1 to 2% need not be disclosed to the patient. If the substantial risk is 10% or more than 10%, it needs to be brought to the notice of the patients or relatives. And congratulations, sir. It's very well covered. And
Thank
just
you,
for the information of the anesthesia colleagues, and as you all know that BNS, okay, that eyepiece is repaired by BNS from July 1st onwards. And earlier, 304A, who used to be booked under 304A,
Now 106,
imprisonment
sir.
for 2 years and plus or minus fine or both. But for everybody's information, as per the new act, okay,
Both.
both are mandatory, okay,
Both.
imprisonment plus a penalty. So we cannot escape from that.
Dr. Sinha, sir, our Tamil Nadu Society Secretary-elect, Dr. Srinivasan is also there. Just I am acknowledged. People are there.
Congratulations to the whole team, sir. It is a very well organized. Okay, I think a lot many.
Congratulations to Dr. Sinha.
Yes, sir. Yes, sir.
Thank you, Dr. Meenakshi, for giving your time. Actually, he has to rush today to start the seminar. He was driving. So there's a lot of rains in his area. So he called me that.
Actually, sir, as an anesthesiologist, we are always prepared. I want to tell you, even my car was hit by a two-wheeler, and that light was also not on. So I was following another car, which is having that red light, and by imagination, I was driving 30 kilometers.
You're taking a lot of risk.
But anyway, that is the reason I called you and said, allow me. Sir, another person is asking, sir, can we get the record version of this webinar, please? Another one is, if anesthesia person is managing 2 OTs, is that legally acceptable? Not at all acceptable. Legally not at all acceptable.
In today's time, it is not acceptable at all.
No, it is never accepted. Sir, can we get the recorded version of this webinar?
Yeah, please. I'll put my number. You send message to me. So
No, that one Muthukumar Rajagopalan wanted to know.
I will just put my number in the chat box.
Right. So thanks for the opportunity.
Just a moment. If anyone wants to ask any question, please raise your hand so that we can utilize the full potential of Meenakshi. So as no hands are raised, thank you again.
No, thank you, sir.
Meenakshi, for
Thank
having
you.
us. I will need your again for some other session.
We will do that, sir.
Yes, sir. Thank you.
Thank you.
Okay, so we call it off. Good night.